Antonio and Samira are in the other room because the session is not finished yet. But I will be happy to just going down. Please.
Okay. Thank you, Mr. Chairman. Ladies and gentlemen, it's my great honor to be here to present a challenging case of ARDS. Oh, sorry. This is a 57 years old female. Ideal body weight was 70 kilogram. And he admitted into our ICU because of fever for 9 days and cough and dyspnea for 1 day. 9 days before, he get a fever of 39.6 degree and with chilly, no cough, no chest disease. And 6 days before, he go to the local hospital and take a blood sample. The white blood cell was a little bit lower, and the lymphocyte was lower. And 3 days before, he admitted to the Department of Infectious Disease, and they gave him some antibiotics, and another blood sample shows the white blood cell was only 1,000 maybe, and the lymphocyte lower, and we see the CRP and the PCT looks normal. And he has a history of hypertension for 15 years, and the highest blood pressure was 140 over 100, and the controlled blood pressure was 120 to over 70 millimeters mercury. Here is the first chest X-ray at the admission to our ICU. And he has aggressive dyspnea, and saturation decreased to 72% with mask oxygen inspiration of 8 liters per minute. And then he was transferred into our ICU, and the diagnosis was severe pneumonia, maybe induced by venous, and severe ARDS, leukopenia, and hypotension. This photo shows the first CT scan at the admission. You see that? Very severe. And the conditions at day 1 of the ICU admission, the patients are weak, dyspnea, but quiet. Its heart rate was 95, and blood pressure normal, without any vasopressors, and the urine output looks normal, 60 milliliters per hour, and the lactate only 1.2. And the patient was on non-invasive ventilation. The IPAP was 23 centimeters of water, EPAP 15, and 100% oxygen, and the saturation was 88%, respiratory rate per high, 35 breaths per minute, and the tidal volume was 300 to 400. And we see the blood gas, the PaO2 was pretty low, only 57, and PaCO2 71. And we did a recruitment maneuver with non-invasive. The IPAP 40 centimeters of water, and the EPAP of 25 centimeters of water, but the saturation did not increase after that. We gave him some oxytocin and some sedation, and the liver and kidney function looks normal. And the question is, what should we do for the next step? We intubated the patient immediately and used deep sedation, even paralyzed the patients and put them into prone position or even to ECMO, or we just keep the non-invasive mechanical ventilation and use ECMO to improve the oxygenation because the patient is weak and he's cooperated.
The question is for you. Is anybody that want answered these questions? From the audience, come on, don't be shy.
The first comment that actually I'm very concerned regarding recruitment maneuver for a patient that's not ventilated, not intubated. with applying of this amount of pressure, this is definitely the way to have a barotrauma. So I'm really concerned. This patient is having BF ratio of 57, and as we discussed in the morning, the weight for non-invasive ventilation for this patient would be, again, not in his favor. I think this patient should be immediately intubated, and then with proper ventilation is to have the consideration whether this patient still lies in the rescue therapy, requires an ECMO, or whatever other rescue therapy, muscle relaxant, proning, or whatever, and then after that to have another rescue therapy if needed.
How was the PaO2 before applying non-invasive ventilation?
Before?
Yes, before applying non-invasive ventilation, because you show us the oxygenation.
Okay, the saturation was 72.
Oh. Yes, of course.
I agree with you in terms of quick intubation, because these patients would probably have a huge respiratory drive. And there is also, I think, data showing that early intubation in these cases, because this is not something it would go in one day. But I maybe a little bit disagree with the fear of the recruitment, because I think most of the pressure that you apply would go from the side of the mask. I mean, it would not be effective at all. And if the patient would be intubated, perhaps I would be more afraid of trying recruit, because it's one-sided at this moment, at least in the first chest X-ray. It may change. So the pressures that you apply could have gone to the better-looking part of the lung.
Can I ask a question? Is there anyone that would have actually not even considered non-invasive ventilation for this patient?
I should have intubated the patient right away.
Yeah, but that's, I thought you asked the other way around.
But, you know, this is maybe a prudent approach, but with an oxygen saturation of 78 at least, just for avoid any emergent intubation in this kind of patients. Also because by applying the BiPAP, you haven't reached, unfortunately, satisfactory result, because you were obliged to use 100% of oxygen, and despite that, the oxygen saturation was suboptimal.
And Massimo, what would be a marker of success if you start non-invasive ventilation of this patient, for instance? How would you define a responder in this case?
Oh, in this case, it's a risky situation, by the way, because how was the FeO2 before the BiPAP? With the 88, the 72 oxygen saturation you mentioned, how was the FeO2 at that time?
FeO2, it's a face mask oxygenation with 8 liters per minute.
8 liters, with a reservoir? With the reservoir or?
No, just the normal face mask.
Any other comment, please?
I think we had a SARS epidemic in 2003, 2004, almost 13, 14 years back, started at this place. And that epidemic, I remember, the mortality was a little high in invasive ventilation group, and the mortality was a little less with non-invasive ventilation group. So thereafter, there is a trend of extending non-invasive ventilation, especially in viral pneumonitis ARDS, because we had managed many cases in 2009 H1N1 pandemia, and our experience is not exactly the same, but more or less similar, that many patients do away with non-invasive ventilation, and especially if the risk of secondary infection is very high, it's prudent to stretch non-invasive ventilation a little bit, but not to this extent.
Samir, correct me if I'm wrong, but if I remember correctly, the SARS was a little bit pathophysiologically different, because it had a very, very, very slow onset. It would take sometimes many days before the patient was really deteriorating, while this is a very quick process, if I see correctly.
Anybody want to comment? Yes, please. So on the other issues.
Thank you. I'm doctor from China. If I'm a resident on call, just met this patient, to simplify treatment, I would intubate this patient because the patient is too stressed. He got the tachypnea, 33 breaths per minute, and the PF ratio is too low, is 75, I suppose. As I study in the morning, I would intubate immediately and did a sedation, and maybe next we'll do the prone position. Thank you.
That's interesting because the audience is almost divided in two different parts, and I'm quite, I think, in a strange position because one, like me, who is fond of non-invasive ventilation, is defending the other part of the story, you know. Do you have any other comment or? Yes, please.
Thank you. And did you perform an echocardiography in the first day or after admission of this patient to a hospital?
Pardon? I cannot hear you.
Did you perform echocardiography?
Yeah. We do echo, transthoracic echo, and we did not find any signs of right ventricular dysfunction and a lot of B types of the lung.
Then, which is the conclusion?
Okay, we go on?
Yes.
Okay, sorry about that. We do a different choice, and we give non-invasive mechanical ventilation combined with ECMO, because of the patient is weak and he's not looks so bad, and so we put him on VV ECMO. The blood flow was 4 liters per minute, gas flow 4 liters. FiO2 60%, and we use a little bit morphine, and the respiratory decreased to 20, and the ventilator parameters IPAP 15, EPAP 8, FiO2 40, tidal volume decreased to around 200, and the blood gas looks good. PaO2 72 and PaCO2 35, lactate 1.3. After that, the patients get septic shock. It's not immediately after the ECMO, it's several hours after the patient was put on ECMO, and the blood pressure decreased to 70/40, heart rate increase, and the central venous pressure only 2 millimeters mercury, and the albumin is a little bit lower, 2.6. And we do flood resuscitation immediately. And my question is, should we use norepinephrine immediately? Or maybe after some intentional fluid resuscitation, for example, 3 liters per kilogram? And should we use a fluid conservative strategy and with a higher dose of norepinephrine to provide pulmonary edema, or we use a labral fluid resuscitation, give much fluid, but maybe the patients will hypovolemic. And should we use albumin for the intentional fluid resuscitation, or just use crystalloid only? Thank you. This question.
My question is, what kind of cannulation did you use in this patient?
Cannulation?
Mm-hmm. For the ECMO.
For the ECMO? The size of the cannulation?
Yeah.
The size?
The size or the site?
The sides and the site. The sides and
site?
the site.
Okay. Formal and here, Venus. And the size, I think it's 24 French and 22 French.
So you drain from the femoral and you put back in the jugular?
Pardon?
You drain blood from the femoral
and
put it back to the jugular?
The drain cannula from the femoral, and the return the cannula from the jugular.
So you have no idea of the cardiac output of this patient?
My cardiac output?
You have no idea of the cardiac output of this patient, did you?
Yeah. We just do echo. Lactate? Oh, yes. The lactate is normal. It's not increased at this time. That blood pressure just go down.
There was any bleeding, and the pressure, the low blood pressure was related to septic shock exclusively, or there was also some bleeding from the insertion sites?
There was no bleeding, but we are thinking about maybe some sedation drugs, and the patient is less stressed than before.
Comments, Maurizio?
It's puzzling a bit that the CVP is only 2, considering you are still on non-invasive ventilation, and you know, the picture seems to be either the patient has been bleeding somewhere or is incredibly dry, or you're not measuring the CVPs.
Yes, please.
Why not to have invasive hemodynamic monitoring on that patient?
Which hemodynamic?
Because like PICO or Swan-Ganz or PICO or any kind of invasive,
Yeah,
so we can get an idea about the cardiac index and the preload and afterload.
I don't think PICO worked at this time to measure cardiac output. So we don't put PICO catheter. We did not put PA's pulmonary arterial catheter in. We just use ICO to measure the cardiac function.
If I may answer, it becomes a bit more complicated here because of the fact that you use thermodilution to calibrate your device, and then the problem is that you inject some cold liquid, which is taken by the ECMO, warmed up, come back. So I mean, you have some losses. Sometimes it's valid, strangely. Sometimes it is not valid. So you can use Doppler, but I mean, the question is invasive measurement. So I mean, the patient is still under non-invasive mechanical ventilation. So esophageal Doppler. No. I think the echocardiography evaluation here is mandatory. I mean, because with echo you can measure the filling pressure, you can measure the stroke volume and so on. But all the other measurements will be much more complicated. And so even though we like to use it, it's the condition where it becomes more on the border for the validity of the measurement.
Yeah.
Daniel, you mean, is the message correct, that thermodilution method is not available in this situation, correct or not?
Thermodilution is often submitted to errors because indeed there is the warm-up of the warming exchange with the ECMO itself. So from time to time, strangely, it seems to be working correctly, and but many times you have difficulties to calibrate. And when you do echo, you can see what is the cardiac output you measure is there, and the cardiac output you have with your measurements. Sometimes there is some agreement, but often there is disagreement.
I think it's not.
Excuse me? Esophageal could be, but the patient is not intubated.
What about continuous cardiac output measurement? It's the same, yeah.
Despite the limits of...
It depends on the cannulation.
Yes, yes, it depends on the cannulation.
Where is the position of the drainage cannula is critical. So...
And your return cannula also.
However...
The return is mixed.
Yes, it's warm.
Oh yeah, but
what would be the best position to be able to look at flow, Antonio?
Sorry?
What would be your preferential position of the cannula so that you can also measure flow?
Well, the femoral is the best.
Yeah.
And femorojugular is good, but you have to be sure that the thermal probe of the Swan-Ganz measures mixed blood flow. That is the trace of the temperature is very important. But anyway.
Yes, please.
Sorry, I probably should. Just that I'm a bit naive about it. Well, I thought in this case, like you are supposed to try to something less invasive first. So let's say we do
well, it's not standard to have patients on ECMO in non-invasive ventilation. Probably there are some patients who do not want to be intubated. And this literature reports these cases.
However,
sometimes we have had patients on non-invasive ventilation and ECMO because they were so compromised or depressed that we thought that intubation was worse than ECMO, but we don't do that anymore. So here,
despite the peculiarity of this situation, however, there is a general agreement that we should measure something else,
yes,
in addition to what we have for the moment. For instance, in a way or another, the cardiac output, maybe with the echocardiography, the Doppler, or whatever it would be.
So this very complex situation at the moment, but first we need to return back to the basics. We need to get the surrogate markers, the other surrogate markers regarding the peripheral perfusion, capillary fill time. We can even do simple non-invasive things like checking the IVC, at least for the caliber. And here you are giving a clue that you are managing septic shock. And so these numbers could be matching with cardiogenic, could be matching with hypovolemic, could be matching with any type of shock. But here you are specifically mentioning that this septic shock pattern, although the CVB is 2, but this is not a preclusion that this could be still cardiogenic.
not very probable though.
Yep, mixed types of shock with cardiogenic plus hypovolemic still could be presenting with this sort of CVB. So basically, there is few studies that have been done in this field. For the ARDS patients is the FACT trial that's telling that we should be trying to do as much as possible conservative fluid strategy. The SAFE study is telling that for septic shock, probably albumin could be, but this different context because this severe ARDS patient. And I would have a lot of concern to give albumin for such patients because these patients will have a lot of capillary leakage and maybe a lot of albumin will be just presenting more whitening of the lungs further and further hypoxemia.
Massimo, we have 5 minutes before we move to the next one.
Just a comment. I mean, we are discussing for 10 minutes, and I think that this patient with this blood pressure is almost dead now. So, so I think that we need to save the patient. And in my mind, with the diastolic pressure, which is so low, systolic pressure is so low, I think that the first question is, I have to do something, and I think and I hope that you will probably tell us that norepinephrine immediately was indeed the first choice to do, and then we may think at something else. And obviously our discussion were quite obvious that the next answer is not that obvious, and that we need to have some other measurements to know if we give fluids or not, because if I look at it, even though we have disturbances with the ECMO cannula, I don't think that it is feasible that this patient has severe right ventricular dysfunction leading to this hypotension. So I guess it can only be, let's say, septic shock or hypovolemic shock. So my attitude here will be norepinephrine because pressure is really too low and some fluids. The choice of fluids, okay, I may give albumin if I have the numbers there available. Without numbers available, I would go for crystalloids, but this would be my attitude at this stage.
What about corticosteroids?
Oh, come on. Please. No, because we have only 5 minutes, and then because we started to save this patient, we would like to know what is going on immediately thereafter, please.
Okay, and we give norepinephrine immediately, and here shows the results of the first 3 days with ECMO, and we see the norepinephrine dose is higher to 0.8, and the tidal volume increased from 200 to 450, and you see the positive fluid balance in the first 3 days, and we know that the increasing of tidal volume really matters, so we put esophageal balloon catheter here is the chest X-ray, and we put a catheter to measure the esophageal pressure. Here is the condition of day 4. The patient is still awake, blood pressure okay, and everything looks not so bad, but the tidal volume increased. Here we measure the esophageal and the transpulmonary pressure. We see that the patient's inspiratory work is very, very hard. And the transpulmonary pressure more than 30 centimeters of water. And so the question, we should intubate the patient immediately with deep sedation and neuromuscular blockers, or keep an IV.
So, is anybody that wants to answer these questions?
We might have answered that already.
Maybe yes.
Okay, then.
What is the blood gases at this time?
It was in the previous slide.
Yeah.
The
The blood gas, I think.
Previous slide.
This one, yes. Lactic is normal, and
BF ratio still very low, and
yeah, PF ratio here. You see the PO2 is
PF
67,
ratio
FO2 is 40%.
BF ratio is BF ratio is 75, right?
No.
75 divided by 0.4.
It's around 200, 180.
Then there is no need for intubation at that time.
But there
But
is
the patient is on ECMO now.
there's no meaning. Is PF ratio on ECMO? It's no meaning.
No, I mean no need for intubation at that time.
No.
If
There's no meaning in the PF.
I know, but
The need for intubation comes from this.
Yes.
You see the swing in esophageal pressure goes to minus 50.
Yes.
So if you let the patient
means high respiratory efforts.
very high respiratory
high,
effort.
yeah.
This patient is really dyspnoic. He's breathing, he makes a huge effort to breathe. He's not an happy patient.
Yeah.
And
Yeah.
we should intubate him to
Yeah,
make him
I
happier.
think, yeah.
Okay.
Little morphine.
We should see if after the intubation will be more happy or not.
We need to come to a close, I would say, in the next 5 minutes. So can you let us know what happened
Yes.
with your patient? Has your patient survived?
What was the outcome?
The patient died.
Because we have been discussing too much.
Maybe yes.
Should act faster.
We were too late for doing the right intervention. So.
Go down.
Thank you so much for sharing this case. We need to move on to